And so you are the med-surg nurse working, and you come in the morning, and how would you prepare for a possible code? Well, the first thing you should do is, when you come in the morning, is identify which clients might be at risk for coding at the beginning of your shift. And then you want to assess that patient head to toe and make sure that patient has a patent IV. But I probably do this next step first. I check their code status, right? You want to know what their code status is. And if they do want meds, make sure that they have a patent IV, because once they code, their vessels are going to collapse. So it's going to be very difficult to start an IV. So if your patient's not doing well, you think that they might code during your shift, make sure they have a patent IV if they want meds. And know your agency's policy and procedure for calling a code. Is there a button that you push? Is there a number that you call? You want to know that your agency's policy and procedure. And then you're going to monitor that patient frequently throughout your shift. So what if you walk in the room and it looks like the patient coded? What's the first thing you're going to do is check for responsiveness. So if they're unresponsive, then check for breathing and presence of a pulse. Now, how would you check the pulse? The best way is the carotid pulse, yes? And so would you check the carotid pulse on the same side that you're standing or on the opposite side? And the correct answer is on the same side. Should you check both pulses at the same time, both carotids? And the answer to that is no. It can cause a vagal response by doing that. So call a code then and ask that a crash cart be brought to the room. Should you go and run and get the crash cart? No, you should stay with your patient. Yeah, so call for help, call a code, ask for somebody to bring the crash cart into the room. And then you want to place the patient in supine position, open their airway, and initiate breathing. Now, if you're in a hospital setting, there should be no reason to do mouth-to-mouth resuscitation, right? You can use an ambu bag. Some nurses do carry a shield with them just in case they have to do mouth-to-mouth, so they get that in their pocket. Although there have been no documented cases of anybody catching anything giving mouth-to-mouth resuscitation. If you have to do that, use a barrier mask. But again, in the hospital setting, there should be no need for that. Use an ambu bag. And then you're going to start chest compressions if the patient doesn't have a pulse. Now, initially, you're going to be alone, so the chest compressions might not be as effective because you don't have a backboard behind the patient, right? So as soon as somebody comes into the room to help you, one of the first things you're going to do is put that backboard behind them. Now, keep in mind that in most hospitals, the head of the bed comes off, and you can use that as a backboard. But on the back of every crash cart, there's also a backboard. So you're going to start CPR until the code team arrives. Now, who comprises the code team? So at the beginning of the shift, if you're working in the ICU or in the ER as a nurse, they're going to assign you to be on a code team. So you know that day you've been assigned to be on the code team. So let's say you're working in the ICU. You know that you're on the code team. You already have prearranged that if a code is called, who's going to cover your patients while you're gone. And so if a code is called, you're going to go to the room where the code is taking place, and somebody will be watching your patients. Who else is on the code team? The code team consists of usually a couple of ICU nurses, sometimes an ER nurse, a respiratory therapist, either an anesthesiologist or a nurse anesthetist. Why would an anesthesiologist or nurse anesthetist be on the team? Because we're going to have to intubate the patient, and they do that all day long. Now, theoretically, anybody that's on the code team has had a little bit of ET tube training, but they've probably never done it, right? And so you want somebody that does it every day, all the time, and so that's why they usually have a nurse anesthetist or an anesthesiologist on the team. And then the physician. Usually it's going to be an ER physician or an intensivist. So until the code team arrives, you're going to maintain CPR. You want to ask unit personnel to clear the room of any unnecessary equipment to make room for the code cart and the team. Now, if you are working in a teaching hospital, there's probably going to be everybody and their brother that's going to try to come to the code, right? If you have nursing students, they're going to come. The medical students are going to come. The respiratory therapy students are going to come. You got to maintain crowd control. You can't have all those people in the room. So clear the room of any unnecessary personnel and unnecessary clutter, and so that the code team can come in with their crash cart. If they have a roommate, move that roommate out of the room if possible. If not, close the curtain. And so now the code team arrives. Each one of those code team members, when they were assigned, they knew what their role was. So each one has a role. One of them is going to be the documentation nurse. Usually in most facilities, the documentation nurse is the nursing supervisor. So nursing supervisors in the hospitals must be ACLS certified. And what's the documentation nurse going to do? Communicate the findings with the code team. So generally they're standing at the door looking in. And then if the patient's on a monitor, they have a good view of the monitor. And so they might be the first to see the EKG changes. So they're going to communicate that. When was the last dose of a medication? So for example, we're going to learn that for certain rhythms, you're going to give epinephrine every 2 to 3 minutes, every 3 to 5 minutes, I'm sorry. And so maybe it's been 8 minutes since the last dose of epi. And so the documentation nurse would tell the team leader, you know, it's been 8 minutes since the last dose of epi. Or maybe the number of doses of each medication. So we're going to find out that for certain rhythms, we give atropine, and atropine has a maximum dose of 3 milligrams. So maybe we've reached the max dose. And so then the documentation nurse would then notify the team leader, okay, we've reached the max dose of atropine. ABG findings, EKG findings, and the length of time since the code began. Once a code starts, it actually, time goes by quickly. And sometimes you're in there 2 hours and it doesn't even feel like it's been 2 hours. And so the documentation nurse would say at that point, you know, it's been 2 hours since we called this code. So they're going to maintain accurate records, and then there's a code flow sheet that's utilized for codes. And they're kind of standardized. Basically, it's the main ACLS drugs that are listed on that sheet, and it's a checkoff sheet, right? So if you give epinephrine, you're going to check it off. There's a time that you record, what time you gave it, what was the rhythm when you gave it, what was the patient's vitals when you gave it. And so you just fill out that sheet. It's I'm going to send you an example of one via email. Another thing the documentation nurse does is maintain timing of the events. What time was the code called? What time was the code terminated? And what was the disposition of the client? Was the client resuscitated and sent to the ICU? Once they resuscitate, usually that's where they're going to go, is to the ICU. Sometimes they go to the OR, sometimes they go straight to the cath lab, but most of the time they're going to go to the ICU. Or the patient didn't make it, right? So the client is deceased. The crash cart nurse is usually the ICU nurse. What the crash cart nurse is going to do is set up equipment for the code team. When we meet, I'm going to show you via Zoom, I'm going to show you what a ampule looks like. They're pre-filled and they're very easy to put together and administer quickly. I'll show you what they look like on Wednesday. So basically just set up the equipment. So have those amps ready. If the doctor wants to intubate or the anesthesiologist wants to intubate, you're going to get that equipment ready. So you're going to need a laryngoscope, an ET tube, and so forth. So get the equipment ready from the code cart. These crash carts are standardized. So you know that what's in drawer 1 will always be in drawer 1. You know what's in drawer 2 is always in drawer 2. So they're standardized. And you see this little red lock here? That, if it's locked, then you know that everything that's supposed to be in the cart is in there. If that little red lock's been broken, then you can't assure that everything that's supposed to be in the cart is there. So they're going to set up the medications and hand it to the code team member that's at the bedside. And then when the code is over, they're going to replace any used equipment and medications following the code. So these crash carts come actually from Central Supply. And they're pre-filled, like I said, they're standardized, and they're going to come back with that red lock on. But what do you actually have to replace is the defibrillator monitor that's on top of the crash cart. You're going to take it off the old crash cart and put it on the new one. Central Supply is going to bring up a new cart when your code is over. You want to make sure there's a backboard on the back of the cart. You want to make sure there's code flow sheets on the cart. You want to make sure there's an oxygen tank. You want to make sure that the defibrillator pads are on the top of the code cart. So those are the things that you're going to make sure that gets switched over to the new cart. What's inside the cart, you know that it's all there because that little red plastic lock is locked. One of the code team nurses is going to be, like I said, a critical care nurse, and that's usually going to be the nurse at the bedside. So that code team nurse is going to actually administer medication. So the crash cart nurse is going to get them from the cart and hand them to the code team nurse. Defibrillate the client. Now, when we defibrillate, we very rarely use the paddles anymore. We use the pads. And on Wednesday, I will show you what the pads look like that we are currently using. Prepare the patient for external pacing as needed. What do we mean by that? You're going to put the pads on them that are external pacing pads. So they're the same pads that we use for defibrillation. You just got to make sure that they have pacing capability. And again, when we meet on Wednesday, I'll show you what I mean by that. Assist with intubation is needed. So what do you need to do to assist for intubation? You want to make sure there's suction equipment available. You want to make sure that there's an ET tube that's the correct size for the patient. Usually it's a 7 for a female and 8 for a male. That there's a, what do you call that? Oh, it slips my mind. What you put inside the ET tube so that you can put it in. Again, when we meet on Wednesday, I'll show you what I'm talking about. You want to make sure there's a syringe to inflate the balloon. You want to make sure you have a stethoscope. And how are we monitoring whether it's in place? Do they have an end-tidal CO2 monitor that they might put in that facility to ensure that it's in the right place? So that's just some of the equipment that you need. You want to make sure that you have 100% oxygen in an ambu bag. So what do you as the staff nurse do while the code team members are there? Maintain crowd control. Again, everybody and their brother can't be coming in. Control the number of individuals that enter the room. Communicate with family members as time allows. Now, it used to be that whenever a patient coded, the family members were banned from the room. They were sent to the waiting room, and somebody would go out there once in a while and give them an update. Now, a lot of facilities are allowing family members to stay in the room. Maybe not all the family members, but maybe one family member can stay in the room with the patient, because studies have shown that if you allow the family member to stay in the room and the patient doesn't make it, there's more closure, because they realize that everything that could have possibly been done was done for their loved one. So many places are now allowing family members to stay in the room. If you are in a facility that allows that, make sure that that family member is never left alone. Somebody must be with that family member at all times. Somebody that has good communication skills, that's explaining what's going on to their loved one. Many facilities now also have a religious representative there as well, a chaplain or somebody to that effect. Make phone calls for additional assistance. So you might have to call the lab, maybe an EKG tech to get a 12-lead EKG. Maybe there's a physician that needs to be called, and you start to make client arrangements. Yeah, so if your patient survives, they're more than likely going to go to the ICU. So if I'm the staff nurse on the unit, I'm calling the ICU and letting them know, giving them a heads up. I got a patient coding right now. They're probably going to come to you and start giving them a report. Or if they're going to go to the OR or the cath lab, start making arrangements. So what are you going to chart if your patient is coding? You're the med-surg nurse on the unit and your patient codes. What are you going to chart? You're going to chart the time of the arrest. What type of arrest was it? Was it a cardiac arrest? Was it a respiratory arrest? Was it a cardiopulmonary arrest? And what were your initial resuscitation efforts before the code team arrived? And then resuscitation efforts after the code team arrived. So generally I would document C code flow sheet, right? Because everything that happened after the code team arrived is going to be on that code flow sheet. So I would make sure that that's in the chart, and in my notes I would refer to them. And then what was the time of cessation of resuscitation efforts? And what was the outcome of resuscitation efforts? So they were resuscitated and transported to the ICU. What happened? So we're going to learn some mnemonics to help us remember what to do in a code situation. Now, I want you to keep in mind that this is by no means an ACLS course. An ACLS course is going to be 3 days long, 8 hours a day, and this is just a overview of what to expect in a code, so that if when you have your first code, you kind of know what's going on, right? So this is not an ACLS course, but a lot of the mnemonics that I'm going to use come from the ACLS course. All right, so what's the first thing you're going to do is ABCD, right? That's going to be your first primary survey. So you're the nurse that finds the patient. You want to make sure they have a patent airway. You're going to open the airway. Now, remember that it used to be for CPR, it was ABC, and then they changed it to CAB, circulation, airway, and breathing. So you start CPR first in the field. In the hospital setting, the reason why they did that is because people that are not healthcare providers, they were taking too long to open the airway and figuring that out. When the sooner you start chest compressions, the more likely the patient's going to survive. But you can quickly open the airway and start breathing with positive pressure ventilation, right? So you want to make sure that both chests are rising on both sides when you give positive pressure ventilation with the Ambu-Bad. And you check the carotid, right? So you're going to check the carotid on the same side that you're standing for a pulse. If they don't have a pulse, you're going to give chest compressions hard and fast, 100 times a minute. And when would you defibrillate? The only two rhythms that you defibrillate are pulseless VTAC and VFib. Those are the only two rhythms that get defibrillated. So it's easy to remember VFib, it's in the name. Ventricular fibrillation, you defibrillate. Now, if you're in the med-surg unit, you're probably going to bring in an AED, right? So you're going to hook them up to the AED, and the AED is going to tell you whether or not it's a shockable rhythm. So if the patient's moving, you're never going to shock them, right? It's only patients that have no pulse, yeah, that you would shock. So they would have no pulse. They would be in VFib or pulseless VTAC. Those are the only two rhythms that get defibrillated. So shock, you shock VFib and pulseless VTAC. So once the code team arrives, they're going to do the secondary ABCD, the secondary survey. So now they're going to do advanced airway control. What do you think that's going to be? Now they're going to put in an ET tube. For breathing, you're going to do positive pressure ventilation, again but via the ET tube. How do you assess for adequacy? You're going to listen now on both sides, right? What if you hear only breath sounds on the right side? That means the ET tube was in too far. How do you fix that? Pull it back a little bit. You're also going to listen in the stomach, right? If you hear air movement in the stomach, where is the ET tube? In the esophagus. That's your most common complication of ET tube insertion, is that they put it in the esophagus. So you want to listen on both sides, listen in the stomach. And then how do we know that it's in the trachea? We can get an end-tidal CO2. We can get a chest X-ray. Circulation, get IV access, and give them now rhythm appropriate meds, and continue CPR. Where is the best place to start an IV? The best place to start an IV is in the antecubital. If you can't get an IV in, then the doctor's going to have to put in a central line. Of course, a central line is better, but that takes time. So if you have to put an IV in your patient's coding, the best place to put it is in the antecubital. And then the D stands for differential diagnosis. Now we're figuring out what's wrong with the patient and try to fix the problem. Okay, so here are the mnemonics that we are going to use to remember what to do for each type of rhythm. Drugs that can be given via the ET tube, remember naval. N stands for Narcan. When will we give Narcan? If it's an opioid overdose. Atropine. A stands for atropine. Atropine is given only for bradycardic rhythms, nothing else. Atropine is given for bradycardic rhythms. Vasopressin. Used to be given one time instead of epinephrine. It's no longer recommended, but vasopressin can be given via the ET tube. It acts a lot like epinephrine. It's a potent vasoconstrictor. E stands for epinephrine. Lidocaine. Lidocaine is an antiarrhythmic that works for ventricular arrhythmias. Lidocaine. So naval. Those are the drugs that we can give via the ET tube if we can't get an IV started. So we can put it in the ET tube, but when we do, we're going to get 2 to 2.5 times the normal dosage. So it's going to be 2 ampules of whatever drug it is that we're giving. And you're going to put that into the ET tube, and then you're going to bag them, and that's going to that drug then is going to get into their circulation via the mucous membrane. So you know, some nurses, some students wonder how we putting fluid into the patient's lung. It's going to be absorbed into the mucous membranes, and it's sterile fluid, and the patient is at this point is dead, right? So this person we are trying to resuscitate. And if we can't get an IV in, then we can give it via the ET tube. Another way that we can give a drug in an emergent situation is intraosseous. So we're going to put it into the bone marrow. And so they use this tool to put in the access. So here we have the needle access, and now we can give the med directly into the bone marrow, and it's going to get absorbed into the bloodstream. So some people think, oh, that's going to hurt. Well, keep in mind that these people are not going to feel pain because there is no pulse. Intraosseous is often used in pediatrics. All right, so what is asystole? Asystole is ventricular standstill. I think that all of these rhythms that are emergent rhythms that require CPR are very easily distinguishable. Asystole you can see from a mile away, yes or no? Yeah, so this could be asystole. There is no ventricular, there's no QRSs, yes? There may be Ps, right? Because it's ventricular standstill, so there's no QRSs. Most of the time, this is what we see, but we could see this. Now, if you see this, it could be that the leads came off, so if they're talking to you, it's not asystole, right? So check the leads, make sure the leads are on if you see this, but this is asystole, ventricular standstill. And the mnemonic for asystole is PE, take out the A. So in about every 5 years, the American Heart Association develops recommendations for ACLS. And those recommendations are based on research. So all these code flow sheets from every code, one copy is going to go in the patient's chart. Another copy is going to go to the American Heart Association. And then they collect all that data, and then they analyze that data, And then every 5 years, they come up with recommendations based on what worked and what didn't work based on the data that they received. And the last recommendation, they stated that atropine should no longer be given for asystole, that atropine should be given for Brady rhythms only. So the PEA, the A used to stand for atropine, we're going to cross that out. In the last recommendation, no more atropine for asystole. So you want to figure, the P stands for problem. Figure out what the problem is. So asystole, the mnemonic to remember the problems that can cause asystole is patch 4 MDs. And we're going to talk about what can cause asystole. So the first thing we're going to do is figure out what the problem is. And we're going to remember the types of problems that can cause asystole by the mnemonic patch 4 MDs. And the E stands for epinephrine. We're going to give 1 milligram IV or intraosseous every 3 to 5 minutes. Now, it used to be that instead of the first or second dose of epinephrine, we're going to give epinephrine every 3 to 5 minutes. The doctor might choose to give vasopressin instead of the first or second dose of epinephrine. Again, the last recommendation, they said that that doesn't work. So we no longer are doing that. You might have an old timer that's running the show that might still give vasopressin instead of the first or second dose of epinephrine, but it's no longer recommended. So you can go ahead and cross that out. So now it's just 1 milligram of epinephrine, IV or intraosseous, every 3 to 5 minutes. Atropine, like I said, is no longer recommended for asystole, so cross that out. All right, VFib, ventricular fibrillation. The ventricles are quivering. Can we not see the ventricles quivering? Yes, so you can see if you shake your fingers, that is what the ventricles are doing. You can see the shaking ventricle. The ventricle is fibrillating, it's shaking. There will never be a pulse with VFib. There will never be a pulse with VFib. They are not perfusing. This is cardiac arrest. And here's ventricular tachycardia. With ventricular tachycardia, they may or may not have a pulse. So you want to check a pulse. Anytime anybody's in VTAC, the first thing you do is check a pulse. If they have a pulse, you're going to treat them differently than if they don't have a pulse. What are you going to do if they don't have a pulse? Defibrillate. What are you going to do if they have a pulse? We'll talk about that later. So first thing you do with VTAC, do they have a pulse? If the answer is no, you treat them just like VFib. So here we have ventricular tachycardia. So what's happening is you have an ectopic beat that's being initiated in the ventricle. So you have these wide and bizarre QRSs. And what's happening is it's going around and around and around and around in the ventricle. It's not coming from the atrium. It's not coming from the SA node. It's coming from ectopic beat in the ventricle. That's why it's wide. And it goes very fast. So ventricular tachycardia, it's beating very fast. And so you may or may not have a pulse with this. So the first thing you do is check a pulse. With VFib, you're getting ectopic beats from all over the ventricle. And so you get this fibrillatory waves. And with these, you will never have a pulse. You always defibrillate VFib. You defibrillate ventricular tachycardia only if there is no pulse. So VFib impulsus VTAC, the mnemonic for that is SCREAM. It's the most important sequence to know because the majority of people who collapse in cardiac arrest are in VFib. And they're going to get shocked. And the purpose of the shock is to cause temporary asystole. So you're going to stop the heart. And hopefully when the heart resets, the SA node will take over again. So the purpose of shocking a patient is actually to stop the heart. It's going to have a momentary asystole. And hopefully the SA node will take over again. So that's going to cause complete depolarization, which will provide an opportunity for the natural pacer centers to resume normal activity. What are the natural pacer centers? The SA node. Okay, so what does the mnemonic SCREAM stand for? S is for shock. There are two types of defibrillators, monophasic and biphasic. The monophasic defibrillators are the older models. Very few hospitals have those anymore. If you're working in a long-term care facility, they may still have the monophasic defibrillators. They're using it until it dies before they buy a new one. The newer models are all biphasic. So with biphasic defibrillators, you need less juice, less joules to shock the patient. So if you're going to shock them with a monophasic defibrillator, the recommendation is to shock them at 360 joules. If it's a biphasic defibrillator, 200 joules. Most biphasic defibrillators, that's the max amount, is 200 joules. On monophasic defibrillators, that's the max amount, 360 joules. So you're going to shock them. After you shock them, you're going to start chest compressions for 2 minutes and then check the rhythm every 2 minutes while you're giving CPR. So then the next thing you do is give 1 milligram IV every 3 to 5 minutes of epinephrine, and you're going to cross out or vasopressin ×1, no longer recommended. The next drug that you would give is an antiarrhythmic. Amiodarone is the first line antiarrhythmic. You're going to give 300 milligrams IV. Lidocaine can be given if amiodarone is not available. It's a second line antiarrhythmic. Amiodarone works for both ventricular and atrial dysrhythmias. Lidocaine only works for ventricular arrhythmias. If you have a type of VFib that's called Torsades de Pointes, the treatment for that is magnesium. And in a few minutes, I'll show you what Torsades de Pointes looks like. So we are going to be going over this several times this afternoon or on Wednesday afternoon. And then again, I think it's the following Monday, we are going to go over it again. So that we're scheduled to do that. Let's see. I have to look at my calendar. I don't have it up right now, but we have two rhythm analysis days. One is on Wednesday and the other one I believe is on Monday the 27th. I believe that's correct. So we are going to be going over this several times before you take your test. Defibrillation. So when do we defibrillate? VFib and pulsus VTAC. You always want to make sure you're doing proper check and maintenance on your defibrillator monitor, because a dead defibrillator equals a dead patient. The sooner you defibrillate the client, the more likely they are to come back. So in the ICU, they generally check the defibrillator at least once a shift. And the med-surg units usually once a day. But make sure that you know how to properly check and maintain your defibrillator. Don't meet the machine for the first time during a code. When you start to work, make sure you get oriented to the defibrillator monitor. And learn the separate controls for monitoring defibrillation. So here you can see, you can put these pads on. Here's paddles. You can put the paddles on and see the EKG monitor, but you're probably going to use the pads, right? You're going to put the pads on, and we'll talk a little bit more about that. And so with those pads, we can see the rhythm on the monitor. And then you can turn the dial to defibrillate, or you can turn the dial to monitor. So you want to make sure that you know how to turn the dial to the proper settings, what you're trying to do. Now that we're using pads, very rarely do we have to put leads on the patient to monitor their EKG. The pads do that. But if you do have a system where they're still using leads, remember that white on right, black on left, red heart if it's a three-lead system. So now we're using these pads, right? So these pads, we're going to be able to monitor the patient on the monitor. We can also pace them if they're pacemaker pads. If there's pacemaker capabilities, it'll say so on the pads. So we can pace them or we can defibrillate them. This is what 99.9% of the hospitals are using now, is these pads. Very rarely is anybody still using paddles. I don't think anybody's still using paddles. because they're dangerous. Think about it. Somebody that's short and overweight like I am, what's the likelihood that I'm going to be touching the side rail when I'm leaning over the patient trying to defibrillate them? Very high. And what would happen if the patient that's defibrillating them is touching the bed when they shock them? What's going to happen? That person's going to get shocked as well. And what's going to happen? Their heart's going to stop. So what are you going to be doing? You're going to be coding two people, one on the floor and one on the bed, right? So they're dangerous. These paddles are dangerous. These are much more safe. Because why? When you defibrillate them on top of them, as soon as you hit this button, this is the button that you would hit, it shocks them. And if you're leaning over the patient and you're touching the bed, very likely you're going to get shocked. But here, you're standing away from the bed, and now the button that you push is not on the paddles, it's on the machine. So you're standing away from the patient when you push the button to defibrillate. So much more safe with these pads. If you're still using paddles, you still need to put a gel on the chest, or you're going to burn the patient. Always do the clearing chant when you defibrillate. So that nurse that's at the bedside that's going to defibrillate, they're going to say, 1, I'm going to shock on 3. 1, I'm clear. So they make sure they're not touching the bed. 2, you're clear. And they look at the 2 people that are giving CPR and that are ambu bagging the patient. They look at those 2 people. They're going to look at them and say, 2, you're clear. Make sure they're not touching the bed. And then they look around the bed and they say, 3, everybody clear. Make sure nobody's touching the bed before they push that button. When you defibrillate somebody, as soon as you push the button, they're going to get the shock at the set amount of joules that was set, right? So for a monophasic defibrillator, it's probably set at 200 joules. Biphasic, 360. Okay, the other mnemonic we're going to learn is pulseless electrical activity. What is pulseless electrical activity? There is electrical activity on the monitor, but there is no pulse. So you might have sinus rhythm on the monitor, but there is no pulse. You might have AFib on the monitor, but there is no pulse. You might have sinus brady on the monitor, but there is no pulse. There's electrical activity on the monitor, but there is no pulse. That's what pulseless electrical activity means. Now, I think that's a very simple explanation of what PEA is, and I guarantee you some of you will get that wrong on the tests, and I don't know why. What is PEA? Pulseless electrical activity. There's a rhythm on the monitor, but there is no pulse. What's the mnemonic for PEA? PEA. Figure out what the problem is. The same problems that can cause asystole can cause PEA. What's the mnemonic for the problems in asystole? Patch 4 MDs. We're going to go over those in a minute. Those are the same problems that can cause PEA, can cause asystole. The E stands for epinephrine. You're going to give epinephrine every 3 to 5 minutes, IV or intraosseous. Or remember, epinephrine is one of the drugs you can give via the ET tube. And the A is for atropine. When would we give atropine? If it's a Brady rhythm on the monitor. So if they have a Brady rhythm on the monitor, you would give atropine. You're going to give them oxygen and fluids because you're going to find out that if you give them oxygen and fluids, that fixes half of the problems that can cause PEA and asystole. So here are the causes of PEA and asystole. The mnemonic is patch 4 MDs. The P stands for pulmonary embolism. What's the treatment if they have a pulmonary embolism? Thrombolytics, break up those clots. If they're coding because of a pulmonary embolism, you got to break up the clots. The A stands for acidosis. If it's a metabolic acidosis, give them bicarb. If it's a respiratory acidosis, hyperventilate them. Tension pneumothorax. What does tension pneumothorax look like, right? You have the tracheal deviation, no breath sounds on one side. The treatment for that would be a needle decompression. Cardiac tamponade. What are the signs and symptoms of cardiac tamponade? Muffled heart sounds, Those signs and symptoms of cardiac tamponade, the treatment for that is emergency pericardiocentesis. So that's the C. Then the 4 H's: hyperkalemia, hypokalemia, hypoxia, and hypovolemia. So if they have hyperkalemia, you can give them insulin that's going to pull the glucose back into the cell. Remember that if you're acidotic, that causes the potassium to leave the cell because the hydrogen ions go in the cell and push the potassium out. So if they're acidotic, you might give them bicarb. You're going to give them calcium chloride to protect the heart. They're at risk for dysrhythmias, and calcium will help to protect the heart. Hypokalemia, replace the potassium. Hypoxia, we're already giving them oxygen, giving them inhalations. Hypovolemia, we're already giving them fluids. And I would add another H, I would add hypothermia. If they have hypothermia, warm them up. This S stands for shivering. I'm not sure why, they just didn't make it hypothermia, so make it patch 5 MD. And MI, the M stands for a massive MI, so they're in cardiogenic shock. So treat the cardiogenic shock, possibly an intra-aortic balloon pump. And the D stands for drug overdose, so do a drug stream, gastric lavage, maybe charcoal. Sometimes dialysis is used to get that drug out of the system. Okay, so I think I'm going to pause here for a minute and take a little break, and then we'll start back in a few minutes.